Hi everyone, my name is Mirsad Begic and I'm a child and adolescent psychiatrist. I work in both private practice and within the public setting. I'm a clinician that works with families and I'm very involved in diagnosing mental health conditions such as ADHD, anxiety and mood disorders, as well as treatment of these conditions, particularly involved in the medical treatment. In terms of a brief overview of ADHD, I thought it was worth talking about the different types of ADHD. So broadly speaking, we have ADHD hyperactive impulsive subtype, about 25% of cases. We have an inattentive subtype, which is roughly 50% of cases. And there's a combined subtype where you have a bit of both, and that's in about 25% of people. The prevalence of ADHD varies between 3 and 8%, depending on which country you live in. Places like the United States are slightly higher, places like the UK slightly lower, and we sit somewhere in the middle of that. In terms of comorbid conditions, so other conditions that might sometimes go along with ADHD, those would include oppositional defiant disorder, anxiety in maybe up to a quarter of people, mood difficulties in up to a quarter of people, substance use difficulties, and tic disorders can occur with ADHD. These can be important because they may require some input and treatment in their own right. Also important to say around ADHD, around what its trajectory looks like. It's a question I often get asked. And what we talk about is that very often the hyperactive impulsive symptoms tend to decrease over time, which is why we tend not to see very, very hyperactive adults. It does tend to get a little bit better, but sometimes the inattention can persist even as people get older. In terms of the evidence base for treatment of ADHD, there was a very large study done over quite a long period of time called the MTA study. And what that looked at was behavioral intervention, medical intervention, a combination of that, or treatment as usual. And really that gave us some confidence that both medication and behavioral management can help. And in particular, that medication seemed to stand out in certain circumstances. So in terms of medical treatment of ADHD, one thing to be clear about is that there's no cure as such for ADHD. The treatment that we use is symptomatic. In other words, what it does is it treats the symptoms for a period of time and then it wears off. So mostly there's not really 24/7 coverage, with one exception, and there's no real cure that we get rid of it completely. So in terms of the medication, what we know, and this goes way back to 1937, I think it was, a psychiatrist called Charles Bradley tested out a stimulant medication for kids in really what was a center for kids that had disrupted behaviors and learning problems. And he used it to see whether it would help with headaches. And they noticed something interesting in that there was a very positive effect for quite a lot of young children in terms of their behavior, in terms of their learning. And this sparked some interest back then. Then many years later in the 60s, a guy called Keith Connors, and people may be familiar with the name Connors because there's a rating scale named after him. He then studied the effect of dexamphetamine and other stimulants on kids that had difficulty sustaining attention and with behavioral difficulties. And from there kind of came the diagnosis, in fact, of ADHD once they discovered that this helped. So in terms of the treatment of ADHD with medication, the first line that we use is called stimulant medication. And the two stimulants we have in New Zealand are dexamphetamine and methylphenidate, are the names of the actual substance. It sounds like a slightly unusual thing to give a child with ADHD a stimulant, but the theory is that it acts on the executive functioning part of the brain, particularly the frontal cortex, and it helps to, I guess, put the brakes on and help people focus and attend and be a little bit less distractible. The medications work on a couple of neurotransmitters, namely dopamine and noradrenaline, and that can be kind of important in terms of interactions with other medications, and usually a pharmacist will be well aware of that, and that's something that you can ask if you ever are prescribed these medications. The response rate to stimulants is roughly 70 to 80% of people will respond if they have a diagnosis of ADHD, which is a fairly high response rate, but there are 10 to 20% of people that just won't. In terms of the target effect, what we're actually trying to get help for is usually inattention, distractibility, impulsivity, and hyperactive symptoms. Um, it's not supposed to be, as some people call it, a behavior pill. And sometimes we get some unhelpful comments from, I guess, particularly teachers and others about we need a pill to control someone's behavior. And that's not really what it's about. It's about the symptoms of ADHD. So in terms of the different medications that we can access in New Zealand, methylphenidate is one of the main substances that we can get. Rightly or wrongly, have funded a whole bunch of different kinds of methylphenidate, different formulations of it, but only one of dexamphetamine. So we tend to use methylphenidate quite a lot. Just so people know, it is a controlled substance in New Zealand and it requires what's called a special authority. So we need to access a special authority number so that we can prescribe it in New Zealand. These numbers last for 2 years and then they need to be reviewed by a specialist, and that can be either a psychiatrist or a pediatrician. The usual dosage regime for methylphenidate is somewhere around 0.5 milligram to 1 milligram per kilogram. I tend to use more around the 0.5 milligram, possibly even slightly less. And really it's about go low and slow and see what works rather than aiming for a number. We find that once we get to the higher end of that number, side effects tend to become much more frequent. And I'll talk about those in a second. There have been some questions about what the maximum dose would be of methylphenidate. We tend not to go above about 60 milligrams in a day. And that's really because most of the studies haven't looked at doses above around 60 milligrams a day. It's not to say it doesn't work, but we're starting to get beyond what the evidence shows. In terms of the different formulations of methylphenidate, and the formulations are just about how long the medication releases for, there's an immediate release formulation, which can last anywhere from 4 to 6 hours, a sustained release, which is slightly longer, and then an extended release formulation. And most people will know substances such as Concerta or Ritalin LA are the most well-known extended release formulations. As I mentioned, with dexamphetamine, we only have one version, and that's the 5 milligram dexamphetamine tablets. And so people know that's probably roughly equivalent to the sustained release methylphenidate in terms of how long it works for. There's a fine balance with the medications around what's too little and what's too much. It feels a bit like a Goldilocks zone, to be honest, when you do use these medications, and that you want to cover the symptoms, but if you push too high, you can get potential problems, which is as it is for many medications. The other issue is that as young children grow, they may well need more medication when they grow, but their symptoms might change. For example, hyperactivity, impulsivity might decrease, so they might actually need less medication. So I often have that discussion with families around, look, we may need more because your child has grown, but we may need less because the symptoms have changed. So it's a fine balance. In terms of adverse effects of stimulant medication, the most common one is appetite suppression. Almost everyone gets that, really. And the concern around that is growth. So very often, if we start this medication, we'll need to do height and weight and growth trajectory to make sure the young person grows. It's also the reason we tend not to prescribe on the weekends or in the school holidays if we can help it. And for many people, that works fine. They don't necessarily have to have it over those periods. Other adverse effects that are not as common but can happen is mood difficulties. One of the ones that we look out for is what's called end of dose deterioration, and that is usually at the end of the day or when the medication wears out. You can get some irritability, teariness, lability type of thing, and that's probably more common than people really think. It can also increase difficulties with anxiety and mood, and I know some people have asked questions around that. So that's something to watch out for if a child has had high levels of anxiety, is to make sure we don't make things worse. There are a couple of other comments people often make is that, I don't want my child to be like a zombie or knocked out. And I'm very clear that that's not what this medication is about. It's not about knocking someone out or making them not themselves. That's a side effect, and that means the child's not tolerating that medication or that dosage, and it needs to be changed. There is some evidence that if you've had Tourette's or a tic disorder, stimulants possibly can make that worse, but there are also reports of it making it better. So that's something you need to talk to your doctor about in terms of whether that's something worth trialing. In terms of other medications, the second line, as we like to call them, of medications, the most common one that people will know of is something called atomoxetine, and the trade name for that is Strattera in New Zealand. So that's a non-stimulant medication, and it's really an antidepressant that wasn't a particularly good antidepressant, but seems to have some effects on both anxiety and on ADHD. So it's what's called a noradrenaline reuptake inhibitor. And this medication is slightly different in that it's not an on and off effect in terms of symptoms. You have to take it for a few weeks before it fully starts to work. And similarly, it has adverse effects a bit more like antidepressants might do, which could be things like nausea, agitation, and mood changes. One clinical sort of bit of feedback that I'd have around this medication is it doesn't seem quite as effective as stimulants, but for some people it can work quite well. In terms of the dosage, we usually aim for around about 1.2 milligrams a kilogram, but going up to around about 1.8 per kilogram. Really, that translates to probably a maximum dosage of around about 100 milligrams for this particular agent. There are a couple of other medications that are occasionally used for ADHD, and those include clonidine and risperidone. Clonidine, there's relatively weak evidence for it, but sometimes it can be popular to use, and sometimes even alongside stimulants. Risperidone is something we don't use very frequently, and it's usually more for extreme aggression and when people have other disruptive behavior disorders. However, it is sometimes used as an augmentation for ADHD when stimulants maybe have not been that effective. I tend not to use it for that unless absolutely necessary and not for long periods of time, given potential adverse effects with risperidone in particular. In terms of other medications and comorbidity, there's no reason that we can't use medications to treat other conditions. For example, if a young person has OCD or a severe anxiety disorder or a mood disorder, we can use antidepressants alongside the stimulant medication. We do need to be a little bit cautious and just monitor for any interactions or problems, but that is something that we do, and I frequently use a variety of other medications alongside stimulants. Melatonin is probably one of the medications that requires a special mention because we do use this medication to help with sleep and what we call neurodevelopmental conditions, and that can be ADHD or ASD. In fact, it's currently funded as an adjunct treatment in New Zealand. It never used to be, and it used to be very expensive. But if there's significant ongoing sleep issues, we can get a special authority now for melatonin as well. It only lasts a year, but that can be really helpful. So the medication that we use in terms of melatonin is called Circadin. It's a long-acting version of melatonin. It's a 2 milligram tablet. Very often that's enough to help with sleep, but sometimes we do go up to 2 or 3 tablets. It's really a maximum of about 8 to 10 milligrams is what we would use. A question that comes up is how young would you treat someone with melatonin? It can be really even at the age of 5, 6, 7. We have used that quite successfully. It's based on a chemical that the brain creates itself anyway to suggest that it's time to go to sleep, which is why it seems to work well for some people. Having said that, it's slightly more hit and miss. For some people, it works wonders, and for others, they find it doesn't work as well. The other question that sometimes comes up is about taking it in pulses, for example, for a few weeks or a couple of months at a time, and there's nothing wrong with that. There seems to be some evidence that you can actually use it, develop a good sleep pattern, and then maybe not need it for a period of time, and then reuse it again.